The new advances with both the masks and also the technology help children to be better ventilated with non-invasive ventilators. So in the beginning, one of the most important barriers to ventilation with a non-invasive ventilator was an interface. So interfaces were not available for small children, and there were very limited choices. So now with having more choices in interfaces, even for smaller kids, it has been very, very helpful. And these masks are now more comfortable and actually can help to prevent pressure sores. And the second aspect is the machines. So the machines now have a ramp which has a gradual increase in the pressure, so that as the children fall asleep, they feel more comfortable with the increasing pressures as opposed to starting with a very high pressure in the beginning. And also there have been advances with triggering. So if for smaller kids who have lower tidal volumes, smaller breaths, it was hard for them to trigger the machines. But now with having different sensitivities for smaller kids, you can use more sensitive setup so that they are able to trigger the machine and be able to ventilate. And it used to be that we were using more pressure controlled ventilation for kids and less volume ventilation because we were trying to prevent pressure high pressure complications. But now with the hybrid methods, what we can do is we can limit the pressure but assure volume so that we have improved ventilation for especially older kids. So this is still not available for younger kids with less body weight, but older kids, this also has improved our ventilation. One of the important things in children with NIV is the compliance. So even if it works, it will only work if the children will wear it. And most studies show that in the beginning, if you support these children with a good mask fit, with a comfortable ventilation, they will continue to wear it. So even before talking about monitorization, we need to really make sure that we have a good start. We have a good understanding of the family's social support and support these kids and also the families, and really tell them how the non-invasive ventilation is helping this kid. And secondly, the follow-up is very important. Now with the increasing help of the technology, we can actually get downloads from the machines of these children. So what we do is we start the child on a ventilator, either in a sleep lab or in a hospital, and then we have them come in maybe in a month and look at the download and ask questions how the machine is working for the child, if it helped with the symptomatology, X-ray and blood gases. And then we need to monitor these kids also in the sleep lab, and that depends really on the age of the child. For younger kids, because of their changing needs, maybe for the mask or maybe for the pressures because their weights are changing and they're growing, this needs to be maybe a little bit quicker, every 3 to 6 months, and then once they're established in older kids, every 6 to 1 year, we need to do a sleep study and make sure it's working, but also continue with the clinical follow-up, make sure the child doesn't have mask sores or other complications that we can actually take care of so that we increase the compliance of the machine. And it's unusual these kids come off their ventilators, but in the case of kids with bronchopulmonary dysplasia, as they grow and add new alveoli to their lungs, they may actually come off the machine. So in these cases, what we do is try the child off the ventilator during sleep first and see if the child still needs it or not.